Hello. Oh, good. Hello, everyone. My name's Sally. I am the mum of Harry, who has cystic fibrosis. He is 6, turning 7 on Wednesday. So we've been lucky enough to be on Trikafta for 1 year. And as the doctor was saying next door, his lung function has improved so incredibly, but it really is the nutrition and the GI stuff that is causing him a lot of headaches. And so I'm so excited to listen to our two presenters today. I wanted to introduce Charlotte Hawthorne, who is from Brisbane. We're so lucky to have her here. She's a practicing dietitian working as a clinical lead at the Queensland Children's Hospital in Brisbane, and her career with children and young people started as a volunteer at the age of 14, ultimately leading to her passion for a person-centred nutrition care in paediatric cystic fibrosis. Charlotte is actively involved in CF research and quality activities at the local, national and international level, and is committed to enriching the lives of young people through good nutrition outcomes. I personally cannot wait to hear your presentation. Thanks, Charlotte.
For that warm welcome, and thank you for allowing me to be here today to speak to you on the topic of post-modulated nutrition in young people with CF. So firstly, I'd just like to acknowledge the traditional custodians of the land on which we are meeting on today and acknowledge and pay my respects to elders past, present and emerging. And firstly, I thought I'd just start with a little bit of an overview of what the service looks like within CHQ or over at the Queensland Children's Hospital, just to give you a bit of context about the population that I'm working with. So we have an active cohort of around 450 people with CF aged from birth right up to 18, or when they transition through to adult care. And approximately a third of our population or our cohort at CHQ is actually managed through outreach. So they're up to far north Queensland or out west. And we have 8 sites which we will visit either twice per year, or we engage and support their local service to manage their CF cares a little bit closer to home. So that's kind of unique to the Queensland population, that large number of our people who are not located centrally close to our facility. We recently looked at our modulator use in our cohort, and I'm sure it'll come as no surprise to you that there's been a significant increase in the number of young people who have access to a CFTR modulator. Our cohort has increased 9-fold in the past 7 years of the people who have access to a modulator. And we know that as access is brought down to a younger and younger age over time, that number will continue to grow. So Ange will be following on from me. We'll be talking about the challenges in the adult population. But firstly, I wanted to highlight what the cohort looks like that we're working with in a paediatric population. So, and highlight the spectrum of care that we have from the age groups that we encounter. So the unique element of paediatrics is that we have a huge spectrum of care. We have the young, really, the early education, the youngest population with CF coming through with new diagnoses. So we have approximately 20 to 25 new diagnoses per year, and we consider them to be what we call a clean slate, where they're born into this era of CFTR modulators and we're educating them from the beginning. We then have the adapters, or the middle age, where they've maybe been born into the modulator era, but we're learning more and more as they grow a little bit older, so they're adapting and learning alongside with us. And then we have the trailing end of the adolescents before they transition to adult care, where they've maybe been born into the modulator naive era, where they haven't been on a modulator for very long, and they're having to learn how to change their behaviours and change their attitude towards their life with cystic fibrosis, and ultimately their nutrition as well. And that can be really tricky. They're going through a really challenging time of their life with everything that comes with adolescence, and then there's also this component too. So I've been lucky enough to attend the medical conference earlier in the week, and we've seen a number of amazing emerging areas of rich research. We know lots about CFTR modulators already. We think we know lots, but there's also so much that we still don't know. So we know that the CFTR modulators have an impact on weight and body composition. We know that they result in reduced energy expenditure. They can change our intestinal microbiome. They impact on our liver function, and we also know that they have a change to exocrine pancreatic function when they're started in a young, early age. We also know that children are consuming more energy and other nutrients than our peers without CF, which isn't surprising when we talk about what we call a CF legacy diet, which is the traditional CF diet that we can all appreciate, which promotes the intake of high energy, poor nutrient-dense foods and overall increased energy intake. We've also found a range of newer emerging challenges from overweight and obesity, metabolic derangements, and also some disordered eating as well. In our contemporary cohorts, we wonder if BMI and body composition are as strong of an indicator to lung function as they previously have been in previous decades. And we have work highlighting the increasing spectrum of disease, and you'll hear a lot of people talk today about individualised care and the importance of how we tailor our approach to the individual that's in front of us and no longer consider a blanket approach that fits all. We've had this echoed throughout many of the research and through many of the talks over the weekend. However, having said this, we know that there's still plenty more that we don't know and lots that we still need to learn as a community and with our consumers. And there's lots of excellent projects on this space to fill these gaps. So recently we wanted to actually understand what our cohort was like at CHQ and how the nutritional status was changing of our young people with CF, particularly with the increased access to modulators from an early age. While we only looked at the cohort in general and we didn't get down to looking at the individual level, we found that our patients who are on a modulator are more likely to be in a healthy weight range, more likely to be overweight, and less likely to be underweight. And we hope to use the data that we have now to be able to look into this into more detail and look at some of the other contributing factors as well. And we know, and you'll hear this in some of the other presentations as well, that these findings echoed throughout the broader Australian data and also across the world. So these graphs are from the CF data registry from a couple of years ago because they really highlight the change in both weight, length or height, and BMI, which is increasing overall over time. So what I did want to talk today is about what we've learnt so far. Some changes have inevitably occurred in our practice with the increased access to modulators, and also, again, constantly come back to that individualised care approach, acknowledging that everybody is unique, that if they are on a modulator, that they're impacted differently to the person that may be in the clinic room beside them, and also consider those who don't have access or are ineligible to a modulator. I'm going to talk through some of the changes that I've observed at my time at QCH. So going back to newborn education, like I mentioned earlier, we have approximately a third of the nation's newborn diagnoses come through our clinic at QCH, and we've seen a considerable shift to the education that's happening for these cohorts over time. We like to use this as an opportunity to set up really good habits from the beginning, and we know that families in this really vulnerable time do a lot of Googling, a lot of information seeking, and they can find out some really damaging information. So we warn them against the CF legacy diet in a really friendly and sensitive way. We encourage a usual approach to solids and a healthy balanced diet and try and normalise things right from the beginning with the support that if increased energy is required, us and their healthcare team will be there as needed to support that. When a young person is started on a modulator, dietitian education is promoted either before initiation or as soon as possible after. We educate on the potential changes that might occur with their body when they start on a modulator. And as we know, we try and educate them around the fat sources that are required to have an effective modulator use. So we're trying to encourage them to incorporate healthy fat sources into their fat required with their modulator where possible, and also incorporating it into an existing meal or snack rather than adding 2 additional snacks in, which might increase the opportunity for increased energy when we know that they already may have a decreased energy expenditure. So when we're looking at growth in our population, we're really trying to empower our clinic to take an individualised approach to growth and move away from the set strict numbers that we've traditionally looked at in CF before. As I mentioned before, we know that BMI may not be as strong of an indicator of health in the long term anymore, and therefore we try to take a holistic approach at actually looking at the young person that's in front of us, considering their overall nutrition assessment, what their goals are, who they are, and take that into consideration when developing their goals. In the absence of an updated clinical guideline or guidance around what any targets may be, that just highlights the need for it to be an individualised approach. We have some centres who are measuring body composition, so they have access to machines where they can define fat or fat-free mass, which also helps give another objective measure to be able to define some realistic goals for that population. And where weight gain or changes to fat mass happen at an undesirable rate, dietitian education to help support weight management and goals towards a healthy lifestyle are encouraged in that CF MDT with the familiar team. In terms of monitoring and nutrition therapies, while we can appreciate the enormous benefit of CFTR modulators, we acknowledge that they're certainly not a cure for CF, and until we have definable objective measures about what we can change for each individual person, we remind our families that nutrition therapies will still form part of their CF care until we know more. Where we know that sweat chloride is known to decrease with CFTR modulator use, we're trying to approach, again, an individualised care to salt supplementation. So considering the climate that that person lives in, their physical activity, their personal, proneness to sweat, their age, their periods of illness, and their symptoms as well. We screen for CF-related diabetes from age 10 with an oral glucose test, but there's also emerging use of HbA1c as an early indicator of changes to glucose metabolism, which we might be able to get a younger person to do if we suspect diabetes but don't want to push them to do an oral glucose test just yet. And then fecal elastase monitoring has also become more relevant with the early initiation of ETI, where we know that pancreatic function may change. So where we have access to be able to get a fecal elastase measure and then also monitor it over time, we might be able to guide changes to enzyme use in our younger population. And then also fat-soluble vitamins, so we continue our annual fat-soluble vitamin monitoring. There's emerging evidence that ETI may have an impact on fat-soluble vitamins, but we're using our bloods to guide any changes. And at this time, there's been no consensus about the monitoring timeframes of when to monitor all of these things. So again, an individualised approach, and it's really based on the centre's access, the family and their care provider. In regard to nutrition support, it's probably of no surprise as we've seen weight go up that we've seen less patients need to access nutrition support, whether that's oral supplement drinks or tube feeds. We have not yet measured the number of patients who've had their pegs removed at QCH, but we certainly know, and we're hearing from all other centres, that some young people are actually having their more permanent feeding devices removed, even when they're going through their rapid growth periods, and they're still able to maintain normal growth without that device, which is a really lovely outcome. And then lastly, I wanted to highlight that educational challenges aren't just for our patients and our families. We also use this education tool to talk to our junior doctors, our medical students at universities, and all of our colleagues when we're doing more broader education. So we know that particularly in the medical workforce, they may be aware of the evidence and the science behind things, but also about what information is available out there for people and their families with CF. So this Google search was done in 2023. And as you can see, it still highlights what we call that CF legacy diet. So just to try and challenge their perceptions of what CF nutrition is and also make them aware of what information is out there for consumers. And finally, I'd just like to highlight all of the resources that are available. All of our dietitians across Australia and New Zealand do a wonderful job at creating resources that are really rich in information and translatable for families of young people with CF, and encourage you to talk to your dietitians if you'd like any information in a written form. Thank you.
I'll just see. Oh, hi. Does anyone have any questions? We might just ask questions now rather than getting Charlotte back afterwards. I can bring around a mic. Okay. Oh, okay, great.
That's an excellent question. Would you like me to answer it, or would you like to? I'm happy for you to. Thanks, Ange.
So another similar question, but back to the kind of pediatric side. Starting on CFTR modulators, is that because that's changing and unknown quantities, pancreatic function, sweat chloride, is that going to lead CF pediatric patients to expose themselves to other things like high blood pressure and that kind of different things we need to look at? Starting the modulators, is that opening them up to different complications that they didn't have previously? So sweat, that's like just diabetes, that kind of thing.
Yeah, another excellent question. So the short answer is that yes, we do know that there are some complications that can come from not even just dietary, but we also know with modulators that it is really important to monitor blood pressure routinely anyway. So I know at our clinic we should be measuring routine blood pressure on every clinic visit now to monitor things like hypertension that may emerge. But we also do know, and I'm certainly no expert in this area, that with young people who are pancreatic sufficient as opposed to insufficient, that there's an increased risk of recurrent pancreatitis. So that's something that's certainly becoming more and more, made an awareness of in our clinic, of those patients that have been started on a modulator early and have transitioned insufficiency, to then do some different monitoring to monitor for pancreatitis that may occur as a result of that change in function. So I guess there are a few things that can change and we're still learning as we go.
That's so interesting. If there's no more questions, I just want to say a big thank you, Charlotte. And my friend Paula will come and introduce Angela.
Well, good morning. It's lovely to see so many people here for this session. My name is Paula Reid and I've had the great honour for the last 14 years of being the CEO of Cystic Fibrosis Tasmania. It's my pleasure this morning to introduce to you Angela Matson, who's going to talk to us about the post-Trikafta diet in adults. Ange is a senior CF dietitian and credentialed diabetes educator, and she's based at the Adult CF Centre in Brisbane, and she's got an incredible wealth of experience over 25 years. She's worked in both Australia and the UK. She's previously been involved in a whole range of things, including co-authoring the Australasian CF nutrition guidelines and the CF diabetes standards of care. Ange has a special interest in glucose abnormalities, GI disorders, holistic CF care, and translational research in post-modulator times. So could you please give her a very warm welcome?
Thank you, and thank you so much for the lay program committee for inviting me to be part of this part of the conference. Just trying. There we go. It's okay. We're all good. Just put this up. Thank you. So part of my talk today will also mirror and overlap from the overview that Charlotte has given this morning. But there will be some differences as well as we move into slightly different aspects. So what I've decided to focus on today is, because we're in an era of changing times and new challenges ahead. So I've been working in adult CF care for a very long time, when Titanic was the top movie of the year. Just to put it into a little bit of perspective there. So at this time, over 25 years ago, government funding was available for our service to establish an official adult CF service. And at that time, we only had 98 adults. We had a mean body mass index of 20. We had a lot of malnourished patients, we had some overnourished patients, and a little bit in the middle of normal. And I want to show you how that's shifting. We had about a third of our group keeping us really busy with enteral feeding, nasogastric feeds and PEGs. And at that time, in hospital service, we had keeping our food service system busy with a lot of high energy diets, a big fridge, lots of complaints of food services having to keep on top of all the high energy milkshakes and snacks. And we didn't make life very difficult for our food service department at all for advocating for our patients. But this early CF diet was based on evidence that the high energy legacy diet and high fat paired with enzymes to really help improve overall survival. And that evidence came from a landmark study, just as you can see here on the left, a Corey study back in the late 80s. And that's where it all started. We had the evidence worldwide. The move came towards a high energy, high fat diet supplemented with enzymes because this study showed that it improved survival overall when the Toronto group was compared to other centres around the world. So this was all quite normal, as you can see over on the right, with lots of enzyme therapy and oral and enteral nutrition. So what has changed? Well, modulators have had the biggest impact, but we were seeing improvements because of general medical and nutritional treatments before this. And as you've seen already this morning, this graph on the left of this trend in our BMI increasing over time. And I've inserted the CF data registry there from the last one, not the little recent leaflets that we've got, which has gone higher again. And over on the far side, we have our clinic, our adult clinic, just showing our percentages of adults in the different BMI categories. And as you can see, the bulk of those, 60%, have achieved a normal BMI range. And we also see underweight and overnutrition people as well. So the spectrum of nutritional care has really increased across all of those areas for us. So in our centre, our mean BMI has increased significantly before and after Trikafta, from a mean BMI of 23 to 25, and that's been reflected in other centres around the world as well. And BMI has increased quickly within 3 months and also maintained at around the 2 years. Body composition studies have shown that this weight gain was usually fat mass, and some studies have also shown an increase in muscle mass response as well. Studies of diet quality have shown that diet quality was low in nutrients and high in fat, and that as fat mass and BMI increases, that the old CF legacy diet for survival is now needing to change. So the traditional diet approach of high energy to improve lung function and improve survival has changed to that of more a balanced, healthy diet to reduce the cardiometabolic risks, the goal being the same, to improve long-term health and survival. However, as Charlotte has touched on in that older group and then into adulthood, especially for adults who've started naive into modulators later in life, and we've certainly had patients anywhere from the age of 18 up until into their 70s start modulators. So change, has anyone tried to change their diet in the room? Is it easy? No, it's not. Dietary behavioural change is challenging, and adapting to reducing energy intakes with healthy eating involves change and relearning diet choices and food behaviours. It involves an individualised approach, as response to modulators is different for everyone, and individuals are all different in terms of food choices, food access, food preferences, food knowledge, food hormones, genetics, activity, exercise abilities, and mental health. So the change needed to many years of diet choices and habits has been challenging. But CF also still has a few unique demands on the digestive system. We need adequate fat to assist modulator absorption. So early animal studies looking at the pharmacokinetics showed that modulators are lipophilic. That means they're attracted to fat and absorb better when they're had with a fat source. So absorption of modulators was 2 to 2.5 times greater when a meal containing moderate fat was paired with the enzymes and with fat sources. So to assist modulators to work more effectively, take them as prescribed with 10 grams of fat. And what that looks like, there's a few little examples up on the far right-hand side of the slide. So eat healthy, but when you have a modulator, make sure it's a healthy fat source, such as milk, dairy, cheese, nuts, or even a small meal, and 12 hours apart. Pancreatic damage, as we've heard this morning, occurs before birth and reduces the production of the digestive enzymes, which means that crayon is still needed in adults, but the dosing may need to be adjusted, especially if the diet and the fat side of the diet has reduced. And it's worthwhile to check in with a CF dietitian to get some individualised advice regarding the lowest effective dosing to help the food be absorbed, but also the fat-soluble vitamins absorbed. So as we know, people tend to experiment and will do things, and I've had a few adult patients stop enzymes as they've stopped a lot of therapies, and consequently fat-soluble vitamin levels are my first clue to that happening as they start to trend down instead of trending up, as we've seen with modulator use. So food behaviour psychology is different for everyone, and food is not always enjoyed due to its association with CF illness, especially in adults. Techniques such as intuitive eating can help to retrain a joy of eating and retraining body cues as part of a healthy lifestyle. A weight-neutral approach is an approach to help focus on the individual and the health rather than numbers on the scales. Other approaches, such as the health at every size or the HAZE approach, is a weight-inclusive model that focuses on improving physical, behavioural and psychological parameters rather than weight loss. This approach considers individual goals, such as physical activity, general activity, emotional health, rather than focusing on BMI. And remember, even those in a marathon come in all shapes and sizes and have their own personal motivation. This method also places emphasis on body acceptance and moving the individual's relationship with food to an improvement stage. This approach can be helpful in adults with a history of body image disturbances or disordered eating. Medical weight loss medications are gaining popularity in the general population, and while studies in CF are very limited, we should carefully consider by the medical team weighing up risks and benefits in having discussions with patients and families around this topic in adult care. So even with changing to a more balanced diet, there are other CF considerations in adult care. The first one on the left is the high percentage of CF glucose abnormalities in adult management. This involves OGTT screening, because without adequate screening, we don't know it's there, and we don't know the prevalence, and we can't start treatment earlier. Diet management is often the first line of treatment now with modulator therapy rather than insulin. In the past, we had a lot of patients that had such a high response to an OGTT that we needed to start insulin straight away for patient safety. But now we're seeing more sort of moderate response to OGTT, and we can initiate treatment with diet or medication approach before moving on to insulin if needed. Some CF centres can assist with endocrine services. Like our centre, our endocrine service is embedded and built into our CF service. Other centres work in partnership or outsource to endocrine care. Secondly, cancer screening. As per the general population, so in our adult service, we do cancer screening for colon cancer in particular from the age of 40. Colonoscopy is advised to screen for colorectal cancer, and we can assist with this from a dietetic point of view by prepping adequately for the scope. And I've been presenting a little bit on that aspect at the conference. As you mentioned before, sodium and hydration. Whilst increased requirements are reduced with modulator therapy, as sweat chloride improves, the response varies, and sodium and fluid needs are affected by living in our subtropical climate, adherence and dose to modulator therapy, activity and exercise. So individual monitoring and advice is required, and further research is continuing in this area. In our clinics, we do spot urinary sodium creatinine ratios and compare those with a FeNO, which is a serum level of sodium and creatinine, to help give more individualized advice on hydration and salt intake, as well as monitoring blood pressure. But further sodium studies are needed. We've already heard this morning that the pregnancy and reproductive health care numbers have increased further than this slide here. It's been the previous data registry information. And also metabolic health. Little is known in terms of our metabolic health for adults as we move forward. So at this stage, we're data collecting and we're monitoring to check for things like blood pressure rates, hypertension, lipids, body composition, diabetes, and healthy heart markers. CF has previously been a risk factor for reduced bone mineral density, which increases with age. So CF centres are continuing to monitor for bone mineral density status as we assess the effects of modulators of bone health into the future. For GI and liver disorders, some improvements have been reported in the literature in markers of CF post-modulator. However, individualised assessment is ongoing and required. Charlotte mentioned about the reduction in enteral feeding, and I've just got a little bit of local data from our centre here. This is a study being carried out at our centre at the moment, led by one of our other dietitians, Felicity, who is assessing the area of nutrition support. So our prelim data has shown a big reduction of just under 40% to just under 8% from enteral feeding, but we're still having quite a high percentage in reliance on oral nutrition support, with the majority of nutritional requirements being met by diet. Some people cope well with this change as we move through PEG removal pathways, others do not. And there's some complex psychology around the change and letting go of PEGs, NGs, and the security associated with a feeding route. Finally, outreach services. As our adult population grows, we'll have challenges in meeting the needs of healthcare from around the state. You've heard a little bit of a summary from Charlotte about their outreach services in PEDS. Adults are less well funded for outreach services. So we currently visit 2 sites in far north Queensland twice a year and take medical staff, nursing, a dietitian and a physio from our team to help catch up face-to-face with those patients with telehealth in between. So nutrition and management, in summary, this varies by age, genotype, medication use, access to resources and services, other comorbidities, physical, mental health, and nutritional health. These are all individual preferences, and interventions need to be individualised based on regular and proactive assessment. Changing times, new challenges, individualised care, and emerging evidence. This is just another selection. It might well overlap with some of the studies that Charlotte's popped up there. The literature in the last few years on nutrition and management has been discussing the changing landscape, both for CF healthcare teams and for all people with CF. As Charlotte has already mentioned, we have lots of resources available. We have online the CF Source resources, and in Queensland, although accessible for anyone, if you Google Nemo and don't click on the fish, if you click on nutritional information education materials online, we love a good acronym. We have, as you can see, listed and summarised on the far side of the screen, all the resources currently available within various dietary areas. So I'd just like to leave you with a quote today from Lauren. Lauren is over in the States as part of the CFF community, and adults with CF have had a challenging time adjusting to lifestyle behaviours. Lauren has posted about her need to find acceptance with weight gain after Trikafta, and this is something we discuss with patients in clinic every week. Change means challenges, but everyone is individual and management needs to be individualised. Your CF teams are looking at research and evidence from across the world, but they're also learning from you and our patients and what is unique to each person. Thank you.
Thank you very much, Angela. That was terrific. Do we have any questions? Yep.
Thanks for that informative presentation. Just a quick question. Understanding that everybody is individual, have you noticed, or is there any data on the eligible patients who are taking modulators between homogenous and heterozygous, sorry, whether there's a stark difference in terms of improvements within the data?
Okay. There are genetic differences in some types of areas, so it really depends on what area that we're focusing on. There are differences in terms of overall health. There are differences in terms of changes in weight. There are differences in terms of things like glucose tolerance susceptibility. So we do know things like the more severe affected mutations are more susceptible to things like abnormal glucose tolerance. But it's, as I mentioned before, it's the individualization. It doesn't always, the phenotype and the genotype don't always cross over, so we very much have to assess people as they come and also be aware of the genetic makeup, but also family genetics, family history as well, and also their history, diet history, medication history. So it's not always the case that heterozygous or homozygous may have differences.
We've probably got time for one more question, if anybody has any. Yep, Lizzie.
Just in terms of adults who've had a long-term exposure to antibiotics, and specifically anything, is there anything coming forward on how to, manage the implications of that, or if there have been any trends?
So in terms of long-term antibiotic exposure,
And any effects on the gut
yeah.
and the different symptoms?
Yeah. So there's quite a lot in the GI literature that looks at gut inflammation in people with CF, and we do know that there's higher levels of fecal calprotectin and not quite as high as the markers that we'd see in inflammatory bowel disease, but higher than normal. The reason for that is varied, and it can be antibiotic exposure, it can be types of diet and gut exposure to fat. It can also be related to radiological exposure as well. There's lots of factors that affect the gut. Yes, you're right. And there's some evidence coming through in the literature looking at different treatment effects. So diet changes, probiotic use, but there are changes that are present at birth as well in the gut microbia. So there's a lot of literature coming out in that field as well. So yes, there is.
Thank you very much, Angela. Could we give her a big round of applause? I'll just finish that topic by sharing something with you. About 12 years ago, I was pitching on behalf of Cystic Fibrosis Tasmania for some sponsorship to a chain of bakeries around Tasmania, and I had to find a really polite way of saying to them that their high-fat, high-sugar, high-energy products and high-salt were absolutely perfect for our organisation. I got the sponsorship because I found a way of saying it nicely. Just a couple of housekeeping matters. The morning tea, which is sponsored by CF Trusted Care, is in the foyer. Thank you very much to both of our speakers this morning. I think you've probably prompted a few other questions. I suspect you'll be in demand during morning tea, but we really appreciate the time that both of you have taken to be with us today. And finally, a little infomercial. For those of you who perhaps aren't aware of cfphysio.com, it's a wonderful resource, and I've got on the back table there, we've got some brochures that the team from cfphysio.com have left. So if you want to grab one of those on the way out, it's got resources for not only the health professionals but for family members and people with CF as well. So I'd really encourage you to have a look at that if you're not familiar with that website. So thank you very much and enjoy morning tea.